Welcome, everyone. Welcome and thank you for joining us today. Today's webinar, Managing Nutritional Needs in Cancer Cachexia, Identifying Barriers to Successful Nutrition Intervention in the Clinic, will be presented by Dr. Thomas Jagoe, whom I will introduce shortly. I'm Michelle Boston, the Medical Affairs Manager with Nestle Health Science, and I'm your moderator for today's webinar. At the end of the webinar, there will be time for questions, and you can enter your questions into the Q&A box to the right of your screen. And we will also have poll questions during the webinar, which you can access to the right of your screen as well. Once the recording of the webinar is ready, at the end, you'll receive an email that will include a link and a certificate of attendance. So today I am honoring the land we are presenting on. We respectfully acknowledge the Nestle offices across Turtle Island are located on the traditional, treaty, and unceded territories of First Nations, Inuit, and Métis people. Indigenous people share a sacred relation with the land, and this acknowledgement is only the first step in learning more about our history and taking action towards reconciliation. Now I would like to introduce today's speaker. Dr. Thomas Jagoe is director of the McGill Cancer Nutrition or CNR Program and medical lead for the CNR clinic at the Jewish General Hospital in Montreal. Dr. Jagoe trained in internal medicine and pulmonology in the UK and completed a PhD on mechanisms of nutritional depletion in patients with early lung cancer. As a Fulbright scholar and postdoc in Fred Goldberg's lab at Harvard Medical School in 1999 to 2002, he studied molecular mechanisms of muscle wasting, ways to identify new genes involved in muscle wasting, including atrogen-1. He and colleagues described common transcriptional adaptations shared by different experimental models of muscle wasting. In 2002, Dr. Jagoe was appointed senior lecturer and clinical researcher at Liverpool University, UK. And in 2007, he took over as director of the McGill CNR Program in Montreal. The CNR clinic uses an integrated multidisciplinary approach to evaluate and treat different aspects of cancer cachexia syndrome in the oncology clinic. With the members of the CNR team, Dr. Jagoe continues to publish research on different aspects of clinical care for patients with cancer cachexia. So we're really excited to have Dr. Jagoe join us today. Just as a reminder, financial support for this presentation was provided by Nestle Health Science, and the views expressed herein are those of the presenters and do not necessarily represent Nestle's views. The material as well herein is accurate as of the day it is presented and is for educational purposes only. So we'll begin the webinar today with a couple of poll questions to learn more about who's in our audience for the presentation. So I'll now turn things over.
Thanks, Michelle, and thanks to everybody who's come along for this webinar. As you can see, there's the first poll question is to try and get some sense from everybody about their current background. I learned from bitter experience that everybody has got a particular take on management of cachexia, and it's often very helpful for us to get a sense of who we're talking to. So first up is if you could fill in the poll about your professional background, that'd be great. Just waiting a few more seconds. So the main results are that the vast majority of those on the call are dietitians, 97%, 2% nurses, and there's a stray 1% somewhere else. We'll see about that. Okay. I think I'm going to move on to the next question, which is also very important, particularly for the subject of the talk today, which is just to get you all to help describe, if you can, or put a category on where your main area of practice is, what type of practice it is, whether it's in a hospital, whether it's home care or primary care, whether it's, a hospital clinic in whether it's inpatient based, whether it's more exclusively palliative care, or whether it's some other context. Again, I'm just going to give a few more seconds for those results to come through. Okay, so about a third of people are hospital clinic based, either in an oncology center or in a general oncology clinic, in a hospital cancer center or an oncology clinic. 28% home or primary care, 23% inpatient, 6% palliative care, and 11% other. So it's a pretty good spread, which is great. And I think you'll all have slightly different takes on what I have to say. But that's really good background. Thank you very much. So once again, thank you to Michelle and Nestlé Health for that introduction and for setting up this webinar. I am going to speak to you a little bit about the team that I'm involved with here at the Jewish General Hospital in Montreal. And the learning objectives for this talk are really to describe the team that I work in and the sort of approach that we take to multidisciplinary working. To outline some of the data that we've collected showing some of the benefits, but also the data that's pointed us in a certain direction, which I'm going to speak about towards the end. And that is a study that focused more on the barriers that we find in managing cancer cachexia. So the first thing to say is I think we've come a long way over the last several years in terms of getting closer to defining cancer cachexia. I don't think we're there yet, and I know that there are other initiatives, including the GLIM initiative, which are trying to help categorize patients in useful ways. But I, at the moment, still turn to this study, which was a Delphi consensus-based paper by Ken Fearon and many of the luminaries in the field at the time. It's now about 12 years old, but it puts some structure on the definition of cancer cachexia, and I'm sure that you're all familiar with that. But there are many other challenges about managing cachexia, as I'm sure you know, and one of the main ones is, well, what is that management going to be? And we're still waiting for data from, or final data from the MONAC trial, which has been running now for the last several years. It's also unclear who's going to deliver management of cancer cachexia, and there's been some nice studies, including some qualitative work from people like Marion Finlay in Australia about how that multidisciplinary team actually operates and whether it's actually being the knowledge of how to manage this is being used operationally very well. And then when is the team going to intervene, or when is whoever's going to do this intervene? These are still things which are still being defined. So I'm just going to spend the next couple of slides telling you a little bit about how we work here, this particular team at the Jewish General Hospital. And it's in this slide is just sort of describing the general flow. Then I'm going to go back over and discuss some of the detail. So we have a referral phase. We accept patients with cancer with these symptoms, which will be familiar to you, with weight loss, wasting, anorexia, and fatigue, or one or more of those. Typically, our people referring to us are oncologists from the hospital, though we are authorized to take referrals from out with this hospital across the province. We do have a steady stream of referrals from dietitians, but we also get referrals from other healthcare workers, including physiotherapists and social workers. There's quite a lot of work that happens before we see the patient, which I'm going to outline in the next slide, but the core team has varied over the years, and it's currently a dietitian, a physio, a doctor, which is me at the moment, and a nurse. And we do an evaluation in the clinic, and then we come up with a series of evaluation outcomes, looking at symptoms, looking at the diet, looking at the activity and exercise level, and we come to some collective conclusion about how to manage these things and then how to follow the patient up. But in addition, we also look to involve other people that may help us, because this is often a very complex equation. And so we reach out to community services, to supportive care, to people like dentistry and other specialists within the hospital where appropriate, and liaise very closely with the treating oncology team. So in detail, I've set it out here. I'm not going to go through everything, but we do spend quite a lot of time trying to get the information already available from the chart about the oncology and medical history, things about current medication, weight history. We do get people to fill in some questionnaires about their diet and about symptoms before they get to us. And we arrange for some blood tests, which are a little bit extended from the usual oncology panel. In the clinic, obviously there's a clinical assessment, and we do some online Teams assessments. Certainly since the pandemic, it was obligatory to do that for a while, and we've maintained some of that operationally. So height and weight symptoms are sort of marked off and confirmed. There is a confirmation about dietary intake going through that diary, assessing functional status. We do a targeted exam, and we also look a little bit more closely at the psychosocial factors that might be at play. And we come up with some outcome measures, which are maybe a little bit more objective, including some physical function testing. Obviously, things like BMI, which we can calculate. For a while, we also did body composition. But we haven't done that routinely throughout this clinic's existence. We assess dietary intake and actually have a calorie and a protein intake rather than just a qualitative assessment. We also have assessments of quality of life and symptom scores. And then after the clinic, there's a team meeting at which we then go through interventions to try and make sure that everybody's on the same page about where we're heading with people in terms of the specific interventions, but also in terms of what the expectations are. And this is something that we are still working on, trying to establish whether this is somebody who really can improve, or whether, in fact, we're dealing with somebody who's approaching end of life and that we need to be targeting slightly different outcomes than we would otherwise. And we also decide on follow-up. So that then leads us to this slightly circular, iterative approach. We identify deficits, look for barriers, try and address those barriers, come up with a plan. The patient goes away and works with our team and then comes back to clinic. We reassess that progress, and then we decide, do we need to continue or adjust something? And if so, then we go round that cycle again whilst they're continuing with their regular oncology care, or it's not necessary to continue with us. And we can discharge and hand over to community services or palliative care if necessary. But in the future, increasingly over the last several years, we've had people come back to us because of status changes after a successful discharge previously. And that's perfectly fine. We just go through the whole reassessment. So that's something which I've seen evolve over the last 16, 17 years since I've been involved with this team. So when I first put the question to the team, this was soon after I started. What are we really aiming for here? What's the main aim of this team? The signal, or the message that came back very clearly was, well, the main thing is quality of life. That's really what we should be aiming to help with. At the time, we were undecided about the best way of measuring that, but we did get that sorted out. We started using this the FACET tool, which is called the FACT with 2 A's questionnaire for cancer cachexia, and we adopted that. And after using it for some years, we went back and analyzed it, and this is the results of a paper published 2018 or 2017. The first author was Monica Palmer, who's the nurse specialist on our team. So this was a cohort of about 370 patients that we went back and reviewed, and it was gratifying to see that both for the total score and this thing called the Trial Outcome Index, which is a subset of the domains within the quality of life tool that we were using, seemed to show a nice steady improvement in quality of life. So that was reassuring, that was validating that we were at least having some evidence that we were doing what we'd set out to do in the beginning. But there are many other aspects to this, and one of the things that we also looked at was what was the relationship between this improvement in quality of life and weight change, or improvement in physical function. And both of those things were correlated reasonably well for a diverse clinical group over the period that we were following patients. And if you've cast your mind back to the 2015, 2016 sort of era, and maybe some of you can't, but at the time, weight change was a good thing, but it wasn't really clear how much that was due to nutritional intervention and how much of that was due to cancer control, how much of it was due to things that might affect metabolic changes like systemic inflammation. In fact, there was quite a strong body of opinion within oncology that nutritional interventions really didn't make much difference at all. Okay, it may help with a sense of quality of life and allowing people to eat or troubleshooting some of the problems they're having eating, but it maybe wasn't so important in terms of correcting cancer cachexia. But that sort of didn't quite tally with our collective experience at that point. So we went on to look a little bit more carefully at the relationship between weight change and dietary intake, but also to try and capture a little bit more some of the patterns that we were seeing in the patients that were coming to us, and to try and identify that there was a subset of patients who were having extraordinarily low diet when they came to see us, and it seemed self-evident that correcting that was going to evidently have a big impact in terms of correcting their features of cancer cachexia. And this is another paper we published in 2018. First author was Rima Nasra, who's was a dietitian on the team at the time. And there are two sort of take-home messages from this. One of them was this panel on the left, which is looking at the patterns of diet, and the red column is really completely inadequate diet. So I forget the cutoffs. I think it's coming up on one of the other things, but less than 0.8 grams of protein, less than 1,000 calories. This in the green column is a sort of okay diet for people who don't have disease. And the blue column is those people who were actually achieving that SPEN guidance of greater than, I think it was 1.3 grams of protein per kilo and greater than 20 or 25 kilocalories per kilogram. So you can see from the first visit to the second visit to the third visit that proportion of patients with the awful diet was dropping off. We were successfully managing to reduce that. There was a good proportion of people who were eating a decent diet, but a very small, less than 20% of patients were eating enough as per recommendations, dietary recommendations, and they were attending a cancer cachexia clinic. So it looked like they were really on the wrong road when it came to trying to maintain their weight. And I think one of the things that we were seeing with our intervention, that we was managing to correct that somewhat, and the proportion of people who were actually achieving those guidelines went up. Not perfect, but it certainly went up considerably. The second take home was that there seemed to be quite a strong correlation between dietary energy intake and indeed dietary protein intake and weight change. So rather than it being just a qualitative quality of life thing, maybe that there was actually an important signal here that correcting dietary intake was actually a really important part of correcting cancer cachexia. And this was still a bit of a hard sell, to other, the wider oncology community. But I think subsequently this message has been looked at in a little bit more detail, and this is a nice paper by Lisa Martin from 2 or 3 years ago, a much bigger cohort. This is 12,000 patients using a surrogate of dietary intake rather than direct measurements, which is what we used. And her take home from this was that, in fact, dietary intake was the strongest determinant of weight loss in these patients with advanced cancer. In fact, it seemed to be stronger at a statistical level than CRP, which was the standard measure of systemic inflammation. CRP did have a role and certainly had a strong role in terms of determining prognosis, in terms of survival, but it was that food intake piece which seemed to reinforce our impression that it was really important to correct that if you were going to have any hope of correcting the features of cancer cachexia. So then the story became, well, okay, what's the problem here? And a lot of good work looking at this idea of symptoms as barriers. You're not going to eat if you have anorexia. And this concept of nutritional impact symptoms was being used quite broadly. And this is a list from list of, I think it's 10 or 11 of those type of nutritional impact symptoms. And people looked at this in two different ways. There was a number of studies that said if you have any of these symptoms, and you might pick one, you might pick pain, you might pick anorexia, you're gonna see that individuals are not eating as much as they should, and that was proven. And then another way of looking at it was, well, it doesn't matter which ones they are, it's the number of them. And this is a very recent paper from this year looking at they had a list of 19 of these nutritional impact symptoms, and when you get beyond about 3 or 4, you can see that there's a correlation between having reduced dietary intake, and so there's this sort of specific or general approach to this. And there was a sense that, okay, this has solved the problem, that if we can get across and get rid of these symptoms somehow, then that's going to be the answer in terms of correcting dietary intake. I think we signed up to that partially, but we were also aware that that didn't really explain what was happening at the individual. And we were seeing patients in the clinic who may have quite marked symptoms, but it didn't really seem to be the main problem about why they weren't able to follow through with some of the nutritional intervention. And there was another factor which I think bears talking about, which doesn't really seem to come up in any of the main literature when you're in this space, and that is how over time, how dynamic the nutritional situation can be. We're familiar with this idea of cycles of oncology treatment, systemic treatment, whether it's radiotherapy or chemotherapy, and how symptoms vary over that time. And I would say that that's a sort of a recurrent nutritional stress. And a lot of the time that we spend with patients is about trying to manage that first week or the first 10 days to minimize losses during that period. So maybe that's familiar, but it doesn't seem to sort of come up when you talk about what to do. But overlaid on top of that, there's a whole bunch of other stresses which come up, which patients with having systemic treatment or on any sort of cancer treatment tend to be very busy with scans, having surgeries, having biopsies, getting treatment toxicities, having other illnesses, getting admitted to hospital with something else. And all of those things on top are changing the situation. So this idea that you can assess people, work out the problem, solve it, and that's done, really didn't tally with what we were seeing in the clinic. And we wanted to look at that a little bit more carefully. So before we get into that, we have another poll, which is just for the people listening in, if you could just, in your experience, this isn't a right wrong thing, it's in your experience or your opinion, which of the following categories would you say was the biggest barrier to successful nutritional intervention, either from your own experience or from what you've read in the literature or whatever other baseline you're starting from? So the biggest group, 50%, is anorexia, 26% other nutritional impact symptoms, 10% motivation, 10% lack of access, and 4% for other. Okay, so that's fine. I just want to then have that in my mind when we're looking at the results of the study that we did, and I'm going to move through this reasonably quickly. So what we did was basically set out in this paper, which you can look at in your own time, but we wanted to drill down a little bit into the types of problems that were stopping people following through with the nutritional advice. And I'm going to explain a bit more of the technique or the methods in a minute. We know that problems with nutritional intake are frequent, as I've expressed. We know also from other studies that nutritional counselling can be effective. It can help, but it seems that people often, even in the context of a clinical trial, don't manage to successfully follow nutritional counselling in usually about 50% of the cases. So, but in those studies, it's not really clear why people weren't able to follow through with their nutritional advice in those studies. So we wanted to look at that, and we were also aware that even though we may have had the same opinion as the people that responded already, that things like anorexia were the real drivers for the problem, the more we looked at it, the less obvious that was the case. So we wanted to look at the range of different barriers that we had come across. We wanted to try and categorize those and then perhaps distinguish between those that were symptom related and those that perhaps were for other reasons, and assess the impact of those different types of barriers. So the way we did that was it was based in the clinic, which I've described, which is an outpatient multidisciplinary clinic. And the way that we did it was we had 2 dietitians working for us at the time. And at the end of each clinic, having seen the patients and had the data from the questionnaires, the dietary recall, the symptom scores, etc., the dietitians would record what they felt were the major barriers as they were sitting there then that were going to impede that patient following through with their recommendation. So it was a sort of in the moment recording, went in the chart, and then we went back after the about 9 months or 12 months of doing this, we went back to extract that data and look at how that correlated. This is the type of patients that we saw, and it's pretty typical of the cohorts that we deal with in our clinic. So mean age of about 66, just under half were female. The majority as a single group had different sorts of gastroenterological cancer and about 20% lung cancer, but we have a whole range of other ones represented. The majority of them had either pre-cachexia or cachexia by the Fearon criteria, and they had the same sort of pattern, maybe slightly different, that I described before. So 30% were eating that poor diet at visit 1, about 50% were in the intermediate range, which would be fine if they didn't have cancer or other comorbidities, but only about 13 to 14% were eating sufficient as per the energy and protein guidelines, and I've sort of set those out here. So this is a list of the symptoms as we had them. So we had a whole range of different symptoms, and having extracted them from the chart, we then tried to synthesize them into groups or categories that made sense. And I know that you could probably categorize them in different ways, but these are the ones that we came up with. So we came up with about 6 that we saw called non-symptom barrier categories, and this ranged from medical problems or oncological problems, conflicting advice, poor motivation, social barriers, food preferences, and then communication difficulties. And I'm just going to highlight a couple of things just to sort of help clarify that. So, for example, in category 1, if somebody comes to us with cancer cachexia, but they also have chronic renal failure, they've already had lots of advice often about the sorts of things to use and to avoid. And there's often a bit of conflict, difficulty trying to resolve that. The same with people who've had diabetes for years. There are also in some situations where people have ostomies, they're very reluctant or finding it difficult to adjust in the ways that we want, because they've got into certain habits to control the output or the volume of the output from the ostomies, and they may other examples are texture restrictions and other medical problems. Dementia is a good one, where it's actually difficult to intervene. The carer might understand, but that's obviously not the person with the cachexia. The other big one, which I'm sure resonates with a lot of people, is conflicting advice. Well-meaning most of the time, sometimes non-specific from the internet, but often it's patient relatives who have very strong beliefs, and when their loved one is ill, we are often dealing with that as a problem because it seems to often lead to confliction with the advice that we would like the patient to follow. And poor motivation. I'm not going through all of these, but poor motivation. There are some people, and there's a number that I can remember with pancreatic cancer, who had been obese all their life, and they weren't that interested in trying to put weight back on. And so we had to maybe shift the conversation and talk about body composition, even though perhaps it would have been better for them to regain a little bit of the weight they'd lost. It was often a difficult conversation. Social exclusion, people being poor, other substance abuse, some other examples, and food preferences, allergies. And some people, this is a domain which is really difficult to get through. We can't seem to communicate with people and get them to understand, but that's something which we struggle with. Symptom ones, I think, are a bit more easy to understand, but we categorize them slightly differently. It's a unusual, at least unexpected for me, how many people have constipation and diarrhea. So we actually classified people with just lower GI symptoms, swallowing difficulties. Anorexia is in there with early satiety, and pain obviously on the list as well. So the results showed us the following, that in our clinic, only about 11% of people had really no barriers evident at that first visit. About 50% had one, or just over 50% had one major barrier. A third of people had two, and 5% had three. We sort of stopped counting at three, because by the time we got three major barriers, that was enough to deal with. We probably, in one or two people, could have listed a few more, but you can see that there's that spread of frequency of problems. And then when we look at the types of problems that we come across, on the left-hand side, you can see that actually the bigger proportion of those people with barriers is actually the non-symptom barriers. So this is the medical oncology, the motivation, the conflicting advice sort of problems. And around a third, 35%, I think it was, had symptom-related barriers. And in fact, if you separate all the categories out, four of the top five problems were actually in this non-symptom category. As I mentioned, we were also interested in this idea about dynamic. Do things change? So on the left-hand side, you can see this is just the frequency or the number of barriers at visit 1 in the orange and visit 2 in the blue. And you can see the profile is the same. So it's not like suddenly when you get to the second visit, there are no problems. We've sorted everything out. There are still problems. In fact, the profile in terms of the numbers looks exactly the same. But when you look at the detail, and I'm not sure this is projecting very well on this on your screens, but I'll try and outline it for you. For clarity, I'm just including those at visit 1 who had either no barriers or those that had one barrier. And if we just start here, what this is telling you is that, okay, in the first visit, no barriers. When we got to the second visit, over half of them, excuse me, did have a barrier to following nutritional advice. So they'd gone from having no problems to having one which was a significant impediment to being able to improve even further. And if we look at those with one barrier, about 50% of them were in the same state at the next visit, but 35 in the same visit, 50% of them had developed a new or different barrier, and 15% had actually had their problem resolved. So this, I think, nicely outlined what we were thinking we would find, which was that things change and how you assess and what you need to do varies as you go through. Our final take home was that we saw something similar to what I showed you before, but we were looking at barriers rather than just symptoms. So as you get a greater number of barriers, yes, it does seem to have an inverse relationship with the amount of dietary intake that we were measuring directly, but that there seemed to be room for hope, and that those patients who had barriers at the first visit, by the second visit, we'd managed to address those barriers and bring up their dietary intake to a similar level to those who had no barriers at the first visit. So in summary, I think this study helped outline that there are many different sorts of barriers which you need to be aware of and perhaps deal with when asking people to follow nutritional intake advice. Very common in cancer cachexia. A large proportion of them, however, don't seem to be related directly to symptoms. And in any one patient, that can vary over time. And it's important to have that ability to reassess and sort of focus your attempts to deal with barriers. But it doesn't mean just because there are barriers that you can't actually address them and that the individual is refractory to nutritional counseling. So I think it's clear now that addressing inadequate dietary intake is a very important part of active nutritional care in managing cancer cachexia. Evaluating patients needs to be quite broad to include both symptoms and other factors, because if you don't do that, you're going to miss a bunch of things which are actually going to trip you up if you're hoping somebody's going to improve with your nutritional counseling, and that you need to repeat that process over time because the situation changes and the barriers change. And to do that, I think it's really tough to do that as a sole dietitian or a sole physician or whoever. You do need a multidisciplinary team, and I think every month, every week, we see that there is value in that, bringing expertise together to identify problems, but also to help try and find solutions. And we often reach out for help for outside the team as well. So that's all I had to say. I want to acknowledge the people that do all the work, which is the other members of the CNR team here over the years, but also our funding from a number of donations through the foundation based at the hospital. Thank you very much.
Thank you so much, Dr. Jagoe. You provided a really comprehensive, yet at the same time concise overview of the work you're doing in the CNR program and how it's really leading to new evidence to help us support the care of patients with cancer cachexia. We now have a few minutes left to entertain questions. As mentioned earlier, please enter them into the Q&A box to the right of your screen. And the first one that I'm seeing here now is someone's asking about what malnutrition screening tool that you're presently using in the clinic.
Yeah, we initially did use the PGSGA, the patient-generated subjective global assessment. We've sort of moved away from that in terms of using it as an individual tool. We've extracted some little bits of that, particularly certain specific symptoms. So we do ask about those, but we basically use the symptom scores, the weight change, the dietary intake, and use that as our sort of nutritional assessment. We don't rely solely on a questionnaire to assess that.
Okay, fair enough. Someone's asked here as well, was the study that you described, was it done before starting treatments such as chemo or radiation? If so, was there another study that looked at barriers once treatments had begun? So I guess the question is, where were the patients in their treatment trajectory?
Yeah, so we see the patients when we see the patients, and I think I've got somewhere here on one of the slides. Yeah, so most of the patients were early in their treatment. I think 70% had either had no treatment or were on their first line of treatment.
Okay.
How many in that particular cohort, how many were actively having chemo, I'd have to go check. But I imagine that it would be the majority, because that's the nature of modern oncology. So I think this idea of we don't actually time our intervention based on what's happening with them in the oncology. You know, we'll see you when you start your oncology treatment. We see people when they get referred to us, and they get referred to us at any point in their treatment.
I was impressed that you got 70% of the people that early in their treatment experience. So that's a wonderful
Well,
outcome.
yeah, it's taken a while, and there's still work to do. But yeah, I mean, I think we've been around for a little while, so people know that we're here.
Yeah, for sure. There's an interest here from the participants to understand if they can have a look at the tools and resources that you use to address barriers. So I think that goes back to people wondering, now that you know this, what are you using to combat it or to address the concerns that have arisen?
Well, again, I don't have a formula for that. I think I would stress the multidisciplinary nature of the team. And if you go to the paper, I think maybe that will help explain, because there's 3 or 4 vignettes that we put in there about different problems, different problem patients that we had come across. Some of these problems you can't resolve, but you can try. And some of them are just very sad. And the one that I'm thinking about at the moment is somebody who had very advanced lung cancer. And for the best intentions, their wife wanted them to have smoothies with lots of vegetables and lots of volume for antioxidants, etc., etc. And that was meaning that the individual in case was filling up with stuff which wasn't really giving them the nutritional bang for the buck that they needed. And so over a number of visits, we were trying to discuss, liaise, change the trajectory of that. The patient was getting full, hadn't eaten enough, was still losing weight. And somehow we were having to have that 3-way conversation. And to be fair, we did make some progress, but it wasn't fully resolved. And eventually the patient said, look, I'm doing this because my wife wants me to do it, and I am going to take that line. And you know, that's what you can do. So we don't have a formula about it. People with dental problems, we get a dentist to help us, often amazing differences. Social workers can be amazingly helpful to deal with some of those access things. Finances are still a problem for many people, particularly in this era, post-pandemic. There's a whole range of different issues, and where we start is with the team. And when we run into a problem, we usually reach out for help. But it's about knowing what you're aiming at, which is what I'm trying to sort of focus on. And if you don't ask about some of these problems, because it's sometimes difficult. We've had a patient, it took us 2 or 3 visits to realize that they really weren't on board with the idea of putting on weight. They would nod and say yes, but they just didn't want to.
Yeah, I've incurred that in the past too. Well, in the space of time, I apologize that we aren't able to get through all of the questions today, but we will do our best to respond to you after when we can. I'd really like to thank Dr. Jagoe for sharing his knowledge and experience with the McGill CNR program with us today. We really appreciate your comments and questions, but we would also appreciate if you could take a couple of minutes to answer the survey. You will find in the left of your screen, there's forms. If you pick that option and click on it, and then you can complete our feedback survey. Then just so you know, again, once the recording is ready, you'll receive an email so that you can go back to it, see the link, and review the webinar again. And you'll also receive access to the slides and an email of attendance. So we'll end the webinar now, and we wish you all the best for the rest of your day and hope to see you at our next event.
Thank you.
Thank you.